Families, building a better tomorrow for children, the role of the social service workforce. Welcome to those of you who are here in the room, as well as those of you viewing online today. I am Amy Bess, and on behalf of the Global Social Service Workforce Alliance and its steering committee, we're happy to be hosting this symposium today. We're thankful to the support from the President's Emergency Plan for AIDS Relief and the U.S. Agency for International Development, as well as the National Association of Social Workers Foundation here in the U.S. As you can tell from today's symposium title, today's event will focus on the way in which the social service workforce supports families and children. There is a growing awareness of the need to collaborate and coordinate across organizations that are providing services and support to children. This coordination is critical to the healthy functioning of social service systems and, at the end of the day, to improving the lives of children and families. All of us here and viewing online are part of that coordination from the many countries and groups that we represent. For instance, some of you may be frontline workers, government employees, NGO managers, association leaders, UN staff, faculty, students, consultants, foundation representatives. I'm sure that there are a few that I'm leaving out. As this coordination and system strengthening has intensified, so too has the focus on the social service workforce. A number of countries have carried out workforce gap analyses in the past few years. Many have developed workforce strengthening strategic plans. Others have designed systems to recognize and train community-level paraprofessionals through certified training. And others are strengthening their social work associations and establishing councils that will register and license social workers. Here in the U.S., organizations like the National Association of Social Workers support the professional development of social workers and are active advocates for the profession. And workforce strengthening has been identified as a core focus in several recent U.S. government documents related to international development, including the PEPFAR Orphans and Vulnerable Children Guidance, the PL 10995 reports to Congress, and the U.S. National Action Plan for Children in Adversity. So who makes up this workforce and what do they do? This is a topic that we'll be discussing more this morning. The Alliance defines the social service workforce broadly to describe a variety of workers, paid and unpaid, governmental and non-governmental, who staff the social service system and contribute to the care of vulnerable populations. One of the main messages of today is that this is a workforce that keeps children and families at the heart of the work. Social service workers promote the inherent strengths in families through supports that are child-centered, family-focused, and community-based. They provide critical psychosocial support and promote the resilience of children and families. They advocate for laws, policies, and programs to promote family well-being. They're researchers and educators. This is a workforce that is grounded in core social work principles and utilizes strengths-based approaches and Bronfenbrenner's well-known ecological framework. But it's also important to note that the social service workforce includes not only social workers, but also other professional and volunteer groups. Throughout today's event, we'll be looking at the role of the workforce that supports families and children at all levels. So those workers at the micro level, providing direct services to families and children. In our first panel, we'll hear about parasocial workers in Tanzania, child and youth care workers in South Africa, and how community caregivers in Cote d'Ivoire are improving child well-being outcomes. In our second panel, we'll be looking at workers at the meso level, or those working to support community groups, such as child protection committees, who in turn promote family strengthening. And in our third panel, we'll hear about those working at the macro level, affecting policy changes and making critical linkages between to enhance cooperation between various elements of the social service system and allies in other sectors. So we recognize that all workers and all of us have a responsibility to see ourselves as part of an integrated, better connected social service system. At the end of the day, having the right number of workers with the right training, support, and supervision will mean stronger support and services to children and families who need it most. The Global Social Service Workforce Alliance was built on this vision of a world where a well-planned, well-trained, well-supported social service workforce effectively delivers promising practices that improve the lives of vulnerable populations. We officially launched a little under a year ago, and since then have been focused on building a community of people who are ardent supporters of improving services to children and families. We've been facilitating learning and information sharing through our webinars and resource library, and we've been convening people and supporting innovation and developing new tools through our interest groups that you'll hear a little bit more about today. We look forward to all of your continued engagement in these conversations about workforce strengthening, and if you're not already a member of the Alliance, we hope that you'll join us and share your experience and knowledge of promising practices with this broader network. I should also mention that the symposium today is timed around a number of other important events. Yesterday, as you may know, was Social Work Day at the UN. This year of 2014 is the 20th anniversary of the International Year of the Family, and the International Day of Families is observed on the 15th of May. And next week, if you don't already know about it, it's going to be a great week next week. We'll be kicking off the first Social Service Workforce Week. And during this week, we'll be highlighting profiles of different workers and featuring blogs on various workforce themes. And these blogs will incorporate links to many different resources that our members have provided. So today's speakers represent a number of very impressive leaders in this field. Along with our many esteemed panelists that we'll hear from today, we're very pleased to have joining us Carolyn Ryan from the Office of the U.S. Global AIDS Coordinator and Susan Bissell from UNICEF. Hopefully you've all picked up the bios of our speakers because our moderators will only briefly be introducing the speakers, and you'll have the bios in front of you. We also have a lot of expertise amongst all of you in this room and online, and we look forward to everyone's input today and involvement in this important dialogue as we move forward. I'm actually today going to start off by introducing Susan Bissell. Carolyn Ryan is just a little bit delayed in traffic, and so she will be presenting after Susan, so we're just going to switch things up a little bit. Let's now welcome to the podium Susan Bissell, the Associate Director and Chief of Child Protection at UNICEF. Susan?
Good morning, everyone. Is there any chance of getting a little more light up here? Distinguished guests, organizers of this event, colleagues from USAID, PEPFAR, others of you that I know from various field postings, some of you who I just met this morning. It's a real honor to be here, and thank you very much both for including UNICEF in this meeting, but also asking me to kick off this morning. It's a real pleasure, and I really do need some light. As I said to a couple of you informally this morning, these are very exciting times, I think, for all of us who are in the business of protecting children, of working with various actors in the social service sector. Many exciting developments, a couple of which I'll touch upon in a few minutes. Our workforce in protecting children, thank you so much. And then there was light. Actually, that's for the Christian Alliance for Orphans meeting I'm going to tomorrow. That's in Chicago. We often say in UNICEF that our colleagues in other sectors have a lot of supplies, and they attract a lot of money. If you're working in health, you can imagine the supplies in terms of immunizing children, the cold chain, et cetera. And if you're working in education, we have all the school supplies. And if you're working in the protection of children, your most important supply item is people, is the social service workforce and the people that comprise that. And I want to just, before I launch into the real substance here, I want to acknowledge in this area the important contributions of PEPFAR and USAID. Many of the most successful interventions in the field, and I'm not just saying that because I'm here and I'm not American, so there's no vested interest, but a lot of work that's really taking off right now and going to scale is really, I think, thanks to the vision of both PEPFAR, USAID, and the National Association of Social Workers here. Also, to those of you that are on the live webcast, I want to say a good morning to all of you, and we look forward to interaction in these new and innovative ways with technology. And I guess the most important thing, and I'll conclude with this as I start with it, together the people in this room and the people on the webcast and everyone that are working to protect the children around the world are a formidable team, and we need to be, because we have huge challenges ahead of us. Now, often when I'm speaking from the vantage point that I have in this incredible job, which I still, after this many years, consider a privilege, I often start out talking about the big picture and the statistics that are so important to us. I'm going to do that again because, as I'm going to say in Chicago tomorrow and the day after, it's a pretty challenging world to be a child in right now. And we have between 500 million and 1.5 billion children enduring some form of violence in their lives. And those are statistics from last year. Some 150 million girls and 73 million boys under 18 who've experienced sexual violence and exploitation. And more than 400 million children living in extreme poverty around the world. Roughly 160 million children between the ages of 5 and 17 are engaged in child labor. That's almost 11% of the population of children worldwide. And there are, and those of you that have heard me speak before know this is my pet project, but there are 230 million children under the age of 5 who don't even have a birth certificate. And I think for all of you working in the social services, you know what that implies in terms of access to health care, education, social welfare benefits, inheritance later in life. So that's why I mentioned that we need to maintain ourselves as this formidable team if we're going to reverse these statistics and get these numbers to zero. At the heart of it is building a social welfare workforce that is, and this is the title of this talk, bigger, better, and stronger. I want to dwell for a minute on the matter of violence against children. And I think it's just really the phenomena that is at the heart of much of our work. There's a scholar at Harvard, Steven Pinker, who he argues that violence is declining, or has declined actually over the last decades and centuries. And I think from a UNICEF vantage point, we would argue back that the benefits of any declines in violence are inequitably distributed, and certainly children experience far too much of it. Violence against children is often unseen, and we know it's underreported, and it frequently occurs within homes and families hidden from public view. As you all know too well, violence affects children's physical and mental health, compromises their ability to learn and socialize, and undermines their development. And we were just discussing at the table the violence prevalence studies that we've been working on, well, now in 10 countries, another 10 lined up to do them. These are prevalence studies. Basically, it's a methodology designed by the Center for Disease Control and government-led and requested surveys, household surveys of violence against children. And based on the findings and the nature and extent of the violence that is reported, there are response plans, intersectoral response plans that are developed to both prevent and respond to the violence. And the findings are actually pretty extraordinary. And the good news is that there is real buy-in from governments in that regard. Last July, we launched an initiative in UNICEF called End Violence. It was a call to make visible the invisible. We were urged as individuals to speak out and to prevent and respond to violence against children everywhere. It was a call also to make visible the many invisible programs and interventions and the people behind them, the social service workforce. The unsung heroes, as it were, with social service workers among those really making a difference in the lives of children. For UNICEF, as with a growing number of governmental and non-governmental partners, systems are crucial. We speak of systems to protect all children from violence, abuse, exploitation, and neglect. And this is in line, as many of you will know, with our move a few years ago from issue-based interventions to programs that privilege prevention together with responses to those affected. Accordingly, law, labor, justice, social welfare, education, and health are all part of the system. So too our efforts to harness positive family and community norms while harmful practices are addressed. I stress the community dimension very deliberately. Community-based actors, as you know so well, can sometimes play an even bigger protective role than the more formal dimensions of a child protection system. Indeed, it is also at the level of community and family that children and youth exercise agency themselves and engage in civic activity. Family. I often refer to this as the first port of call in protecting children. But sometimes family is broken. Drug addiction, HIV/AIDS in the household, unemployment, violence, poverty. The list is long and the stressors of family many. The social service workforce has a very clear role when that port of call that is supposed to be working is not. In fact, that very workforce interacting with its many moving parts can make a difference between the life and death of a child. Our goal is to preserve that life, each and every life, and to help children and families thrive in safety. This requires that our entire human society, from government to non-government agencies, from the leaders in their villages, communities, to religious groups, and to families and children themselves, put in place a system of protection to prevent harm from happening and to address it when it does. I want to continue for a moment on family. As we heard already, 2014 is the celebration of the 20th anniversary of the International Year of the Family proclaimed by the UN General Assembly. And I want to share a few words that were said at that time 20 years ago on this proclamation, words which underscore the role of the social service workforce. And in quotes, programs should support families in the discharge of their functions rather than provide substitutes for such functions. They should promote the inherent strengths of families, including their great capacity for self-reliance, stimulate self-sustaining activities on their behalf. They should give expression to an integrated perspective of families, their members, community, and society. And I think 20 years later, that still holds very true. Working with families in policy development and service provision beyond a specific focus on women and children is bound to result in improved outcomes for all family members. And this is just as critical with today's socioeconomic context as it was 20 years ago. Families are enormously complex today. Think of the ongoing struggles of the people of Syria fleeing their homes, likewise in southern Sudan. Think still of the millions living in extreme poverty everywhere. And take on a third mental image, that of the blended and extended family caring for the elderly and raising the young. Intergenerational solidarity, indeed, but for many, amid obstacles, financial and social, at every turn. The social service workforce is about people, preventing and responding to harm. People, be it members of the community, social workers, members of institutions, religious figures, working with children and families to help them face the many challenges of life. People addressing different generations, helping the mother of a newborn, and supporting the elderly. That help and support also mean fighting discriminatory attitudes and practices and shifting societal behaviors. This is a tall order, even for the most robust workforce. Developing a bigger, better, stronger social service workforce is part of strengthening a child protection system. As I've already noted, this is a hugely challenging endeavor. It deserves our utmost recognition and appreciation. And I say that knowing that already there are many efforts underway in both the official institutions and more informal settings. At the same time, much remains to be done. to improve the quality of services, align trainings with field realities, make sure that qualified staff stay in the workforce, better monitor the impact, and to share lessons learned. And I'll go out on a limb here and say also to seek the kinds of pay that are afforded to other parts of workforces. I was at a child labor meeting in Brazil last year, and I shouted out very similarly for the educators in our communities to get the recognition and respect that, for example, the health workforce achieves. Just now, I'd like to share a few examples of work in the field relevant to our deliberations today. So the first is in Iran, and in its provinces with the highest numbers of juveniles detained by law enforcement, we've been conducting training on provisions of the 2013 Islamic Penal Code. This was designed for judges, prosecutors, lawyers, and social workers. It focused on the best interests in rulings, diversion away from judicial proceedings, and alternative measures to detention. Another example, in Tajikistan, we produced first a manual for social workers to conduct group work sessions for children in contact with the law, to illustrate how to handle problems differently and how to improve interaction with their environment, as well as a manual for the staff of police reception and referral centers to help them keep children involved and busy during their short stays there, for example, for runaway children. Disability is also a factor in our work, and in, for example, Montenegro, we had a communication campaign called It's About Ability to raise awareness about the rights of children with disabilities and promote non-discrimination. Alongside multiple activities with the media, we worked with the government to increase the number of children with disability in mainstream education and with residential care providers and social workers to support the integration of children back home. We promoted a better acceptance of children with disabilities through clubs of volunteers with and without disability in partnership with parents' associations, schools, daycare centers, and social workers. And my final example, and probably an odd one in some ways to many of you in the room, but in thinking about our work with child soldiers or children formerly associated with armed groups. In Nepal, after the peace process of 2006, we worked on the discharge of thousands of minors, part of the Maoist army. This assistance included psychosocial support, formal schooling, vocational training, help with setting up small businesses, and community-level peace-building activities. Social service workers were at the heart of all of these efforts. In each of these examples, we see exemplary workers, police and judicial personnel, social workers, communities, neighbors, teachers, the media, and civil society working together. Social service is undeniably inter- and multidisciplinary. The more united the social service workforce, the greater the impact. But there's a flip side to this, and I want to acknowledge, and we met outside the room, Dr. Catherine Love. She's here today, and she'll be speaking. She can easily remind us that the workforce can also do harm. In Maori culture in New Zealand, it is normal to have children at an early age. However, child protection is focused on preventing early motherhood rather than supporting and educating young mothers on what they will need to do in their new roles. There are endless other examples, including those where people with good intentions but no training are taking their efforts too far. And those tragic examples of harm done when there is little or no coordination. What springs to mind for me as a displaced Canadian in New York at the moment was the case of a 4-year-old boy a few months ago. He was known to the social welfare services, he was known to law enforcement, he was known to his neighbors, but no one added up the pieces that he was being abused and neglected. All of that was known, and he died. And I actually had, who's the famous economist? His name will come to me, living in New York, and we went to meet him, Jeff Sachs, on the post-2015 agenda. And he actually said to me, why can't you do something about fixing the child protection system right in New York City? And that example of a lack of coordination is, I think, it speaks to us wherever we're working on these issues. I want to conclude my remarks, though, not on this tragic note, but with a view to the future. First, capacity building is crucial. I've seen the child protection sector grow and develop globally during my 25 years with UNICEF. And I've never seen greater chances to build this marvelous interdisciplinary discipline. Those of you that know me better than others know I walk around with a pretty long face most of the time. Not enough money, too many demands, more Security Council resolutions. But this is actually a great time for child protection, despite the fact that the world's a pretty terrible place to be a kid right now. One opportunity that's long-term and visionary but very exciting is a partnership we're working on with Harvard, an advisory group of experts from India, South Africa, Scotland, Ethiopia, and Mexico. We're developing a graduate-level curriculum that will be available to anyone in any discipline, which will bring together various aspects of child protection. This is a master's concentration in public health. In 3 years, the curriculum will become a public good, and ideally the advisors will seed the program or some version of it in their home countries. As part of the Child Protection Working Group, we're also creating a postgraduate diploma on child protection and emergencies. This is being done with the University of KwaZulu-Natal in South Africa, which has just been accredited by the South African Council for Higher Education. I know that some of you in the room are associated with this vitally important work. And it's just about bringing this discipline to another level, seen as an interdisciplinary discipline, taken seriously, given the kind of profile that it very much deserves. Advocacy about the importance of protecting children is clearly yielding attention, and we need to direct some of that advocacy to capacity building of the social service workforce. And I'm going to reiterate a couple of things that you had mentioned already. On the 18th of March 2014, World Social Work Day was celebrated around the world on the theme Social and Economic Crisis, Social Work Solutions. Yesterday was Social Work Day at the UN. This year on the theme of Social Work Practice and Education, Voices on the Post-2015 Development Agenda. Also noteworthy is the fact that every year on the 15th of May, the UN celebrates the International Day of Families. And importantly, as you mentioned, next week, starting on Monday, the 5th of May, the Social Service Workforce Week will be launched by the Alliance. I feel confident that our advocacy will lead to important outcomes for children. And listening to you, it made me think we need to find some ways to link your link to some other places that will actually get the word out. And I think if we look at the development of other sectors and other areas of work like maternal and newborn child health, it is advocacy in part, it is data in part. It is the academy, in part, that brings these things more to the fore in the way that we would all like to see them. So just briefly, as I come to the end of this, a comment on today's symposium. You touched on a little bit the 3 panels, but I wanted to elaborate a little bit. The first panel will look at how direct services are provided to children and families of populations affected by HIV and AIDS. The second will highlight how communities and traditional structures are involved in child protection and how to build their capacities, including on ways to better link with national formal protection systems. And the third, the last panel, will focus on the intersectoral and integrated nature of the workforce between different fields, ministries, state, and non-government actors. I want to congratulate again the organizers of the event today and express UNICEF's solidarity with this vital work. Thank you.
Thank you very much, Susan, for those comments and for your support for the social service workforce and for the Alliance as well. So now let me welcome to the stage Carolyn Ryan. Dr. Ryan is currently on detail from the CDC to the Office of the U.S. Global AIDS Coordinator, where she serves as the Director of Technical Leadership for PEPFAR. Caroline?
Well, good morning, everybody. I also am a displaced Canadian. So I'm not really quite sure how we all ended up here, but it's a long way from Saskatoon. So I want to thank Amy and also thank you at the Global Social Service Workforce Alliance for inviting me to speak with you today. Over the past 10 years, as many of you know, the President's Emergency Plan for AIDS Relief, also known as PEPFAR, has been very invested in supporting over 5 million children affected and infected with HIV and AIDS. And we are a large funder of programs for vulnerable children as a result in the world. And we're well aware of the substantial contributions of the social service workforce within our own programming. In fact, PEPFAR has really taken on spearheading some of these efforts globally along with other stakeholders. Over the past decade, in an effort to increase the sustainability of our programming, we've been supporting investments in systems, both health systems and in social service systems, and in ministries of health as well as ministries of social service. And the workforce that needs to be supported within the latter ministries is always quite weak, and so it's been an area where we've really tried to focus on ministries that have not always received enough funding through their ministries of finance and have not always been inclusive in the health sector. So as a health professional, I have a great respect for what social workers do. I used to work in Seattle, Washington, and I had an AIDS clinic there with the University of Washington. And really, it was a team. It was myself and the social worker were the primary providers. And I don't really know, I mean, what I was doing was 1/10 of what the person needed. And it really could not get people to take their medications or be compliant or come back without the reinforcement of just the social worker and what it took to organize the rest of their lives. And as my friend Nicole Benham often says, people spend 1/10 or 1% of their life in a clinic and 99% of their lives at home dealing with all the other issues that will really make it or break a clinician's regimen for them. I think we should be aware of what a daunting job we have in terms of just the sheer numbers. You know, we talk about the sheer numbers of doctors and nurses, but it becomes even more sobering when we look at the sheer numbers of social workers. So the ratio of social workers to the population in Ethiopia is 1 per 120,000, and in Lesotho is 1 in 100,000 respectively. And the turnover is frequent. We know that half of the social service workers employed in Southern Africa leave their jobs within 5 years. And that's compared to healthcare workers that leave their jobs on average every 7 years. So these are frightening, but I'm sure they're very familiar statistics for you. And the factors that influence these statistics are also familiar. Like healthcare workers, social workforce often faces funding constraints. Data to support planning is often outdated and inaccurate. Systems for recruiting, hiring, promoting, and retaining are not existent or slow or frequently fail to deploy the worker to the regions where they're most needed. In addition, educational opportunities are inadequate to meet the social welfare needs, and also burnout rates are very high. You can imagine a caseload of 100,000 people. That really would be a burnout. Also, there's low salaries, there's poor workplace conditions, there's insufficient job tools, and there's a lack of appreciation for the very difficult tasks carried out by social service workers. So let me once again reassure you that PEPFAR recognizes this. We appreciate the social service workforce, and we are committed to continuing investments in workforce strengthening. In 2010, PEPFAR sponsored the Social Service Workforce Strengthening Conference in South Africa to identify ways to address these challenges more effectively. The conference brought together teams from 18 countries, and they were comprised of members of government, academic institutions, professional organizations, civil societies, and donor groups. And together, these teams reviewed what is the current status of the social service workforce. They shared their experiences, and they tried to develop concrete plans for future strengthening of the workforce in their countries. Since that time, PEPFAR has worked with these same stakeholders and others to implement action plans, and it's been very promising, and I'll just share a few results from that experience with you. So in Zimbabwe, the Council of Social Worker supports, with PEPFAR support, a project called Vana Betwana, which is, we'll hear more about it today. It's working closely with the Department of Social Services to operational bylaws that allow the private social workers to carry out specific statutory functions that were previously carried out by public social workers. This willing enhancement, the public social service workforce without the need to provide new public health service posts. And then after 10 years of piloting a project in South Africa, this project has now received about $444 million over 5 years and has trained 10,000 community-based child and youth care workers through a program that has been supported by PEPFAR and is called ISBINDI, and I think you'll also hear about the ISBINDI project today as well. And lastly, in Tanzania, PEPFAR supported, with efforts from the Prime Minister's Office, a regional administration and local government, the creation of a new cadre of social welfare assistants. And these assistants are working at increasing the funding available to the direct level social worker position at the regional and local levels. Several countries have also introduced new social work certificate, diploma, and degree programs. And Mozambique now supports the translation of a certificate-level training program for community workers into Portuguese, and the program has been endorsed by the Ministry of Social Action and approved by the National Accreditation Board. They're also supporting training institutes in Malawi to finalize social work diploma and degree programs. And we're also partnering with the Tanzania's Institute of Social Work to train 4,000 parasocial workers. And this is supported by also training what are called social welfare assistants, and that's via a 9-month certificate course in the Institute of Social Work. And finally, many countries have invested in efforts to strengthen the social welfare professional associations, and the Tanzania Association for Social Workers and other key stakeholders has now formed a task force with the intention of developing a social work council that will regulate the social service professions. So the Global Social Service Workforce Alliance, which we're celebrating today, is yet another idea proposed at the conference that has changed the way that we understand and support social workers for the better. The Alliance has provided us with a common language and framework for talking about the workforce and what they do. Through a very successful and well-attended webinar series, the Resource Library, and other initiatives, they have highlighted new tools, resources, and methodologies, and provided a forum for sharing these ideas across countries, identifying common struggles, and promising solutions. This has been a dynamic first year. This will be a hard act to follow, but we know that the Alliance is well positioned to continue to grow its membership, to raise the profile of workforce worldwide, and to enable the workforce to support children that are affected and infected by HIV and AIDS, as well as other vulnerable children, and effectively as possible to lead to mitigation of many of the things that lead to disease and to poverty. PEPFAR is proud to be a founding member and supporter, and we look forward to this continuing partnership. Thank you.
Thank you, Caroline, for those remarks, and again for PEPFAR's ongoing support for the social service workforce. I will now call to the podium our first panel, and let me introduce Kate Tulenko, who will be moderating that panel. Kate is the Senior Director of Health Systems Innovation at IntraHealth International, and she's also the Director of the Capacity Plus project. And also joining her will be Zeni Tumbadu, Nathan Linsk, and Kendra Blackett-Debinga.
It's a pleasure to meet you all. When Maureen Mendenhall from USAID approached Capacity Plus about 4 years ago to do work on OVC and the social service welfare workforce, we were just delighted because Capacity Plus looks at the entire health team and realizes that if you just focus on clinical workers, you only address a fraction of what true health is. And we work in countries where often less than 5% of people access higher education, so relying on a master's level social worker doesn't necessarily work. You need different models of a social service workforce with paraprofessionals, community health workers. You also need to help professionalize this workforce, as has been mentioned, having job descriptions, career ladders, voices within ministries, formal training programs, and professional associations and continuing professional development. It's an additional challenge because in many of the countries we work in, when you define a vulnerable child, whether it's by hunger or lack of access to health care, non-enrollment in school, loss of family members, the majority of children can be defined as vulnerable. So the challenges are indeed huge. In the panel today, we're going to talk about how we can support families to better deliver the care that children need to grow and thrive. Our first speaker is Dr. Nathan Linsk. He is the founder and currently the co-investigator of the 7-state Midwest AIDS Training and Education Center. He's professional of social work and family medicine, University of Illinois, Chicago. And he will discuss community-based workforce of social service paraprofessionals, outlining the critical work they do in strengthening families, the challenges they face, and the next step in the global contribution for strengthening the workforce. Our second speaker will be Zeni Tumbado, the Deputy Director for the National Association of Child Care Workers in South Africa. And she will discuss a model of community worker called the Community Child and Youth Care Worker in South Africa. The model has established program standards and is being scaled up nationwide in South Africa. And our third speaker is Kendra Blackett-Dabinga, the Acting Senior Director of Child Protection in the Department of Child Protection and HIV/AIDS at Save the Children. And she will present findings from a recent study looking at the role of community workers in the uptake of critical health and social services. And this is one of the few research studies focusing on the actual efforts of community health workers to successfully link families with services. So thanks again, and our first speaker is Dr. Nathan Linsk.
Set this down. Good morning, and good morning especially to all those people who are tuning in via the web, because I know there are many people from many countries who are registered and hopefully tuned in correctly. I'm going to talk a little bit about paraprofessionals, and specifically about how paraprofessionals fill gaps in the workforce, and tell you a couple of stories, one about some of the work that we've done in Tanzania that Dr. Ryan has mentioned so far, and we appreciate that, and also what the Alliance has been doing to try to begin to focus on this particular area. So I thought we'd start with one of the most contentious issues of all in this particular area. What do we mean by paraprofessionals in the social welfare or social service workforce? And I think we all know what we mean by paraprofessionals. Those are people who assist, participate, do particular kinds of work under the supervision and guidance of a professional who is competent to oversee what they do. Now, that connection is not always so strong. However, that's the ideal. And we'll be talking about some of the principles that we're concerned about, but it's someone who can fill those kinds of gaps with training and support. And I have a definition here of that originally was called parasocial worker, but when I took a look at it later, I realized that it really does more or less define what we mean by parasocial service worker. And you'll notice this word, paraprofessional social service worker, or these words have begun to evolve and catch on, which we're very excited about. I'm not exactly sure what they always mean, but what we're talking about here is a supervised paraprofessional staff or a volunteer, often or generally community-based, who serves the needs of children and families, particularly where social welfare systems are underdeveloped or severely stretched. Now, I want to let you in on a secret. This is not a new idea. There have been paraprofessionals, social work aides, social work techs. I'm sure the same thing is true of child and youth care workers and community development people and all the other array of groups that try to support children, families, and other vulnerable populations. But this has come alive and been applied in a way that's really integrated within the social service workforce, and I think that's where the novelty comes in, and that's where the hope is for the future. So, some of the things that they do, and some will look familiar to you, is they identify people at risk, establish relationships with those in need, assess strengths and needs, develop service plans, and implement those plans, provide supportive counseling or psychosocial support, especially in times of crisis, and it's up to the limits of their ability, which we'll get to in a minute, link clients to services, and follow up through some kind of case coordination or case management, provide ongoing support in problem solving, documenting service needs and service provision, and as I said before, this is all done up to their level of ability. And so a lot of the training is training about what you can do and what you can't do, given these limitations and structures. And I will admit that my bias is social work oriented. I was a professor of social work for many years and work in the social work field. However, I think that many of these things apply to all these areas, and that's part of what we've been trying to work on together. So briefly, I want to tell you that in 2006, I found myself doing a Fulbright in Ethiopia where we had worked to establish the School of Social Work, and I was approached by a group called the American International Health Alliance Twinning Center and asked to go to Tanzania and to try to strengthen the academic programs at the Institute of Social Work that was mentioned a little bit before. And when we got there, we were told we would do a little bit of training to try to get the faculty out into the community to empower community people to be involved in social work services. And we developed what's called a twinning partnership at that point between the Jane Addams College of Social Work and the Institute of Social Work in Tanzania, and the focus evolved a lot over time. Because then one of the first things we wanted to do is meet with the Department of Social Welfare and figure out how we could make that fit. And they wanted us to do all kinds of training. They told us that their workers hadn't been trained in many years. There was a little bit of HIV training, not much. What could we do to help? How could we help them with documentation, report writing, and lots of other things? And so we constructed a program that we would try to do together using the faculty of the Institute. And we piloted it in, whoop, all these buttons are confusing me. Just bear with me. You can look at the parasocial worker and the client there. In March of 2007. And the program took off. The first, we did the first programs in Dar es Salaam and some other places around there. We went to other parts of the country, and people got interested in this. And we were asked to scale it up, first from 120 to 300, and then we were told, well, we should get to 5,000 in the first year. So at that point, we got involved with InterHealth. And they got involved particularly in the area of helping us to coordinate these programs as well as integrating them into local systems, and created a very strong link. And we developed this program, and we've so far implemented it. The numbers are a little bit confusing because it's a 1 year almost. And people come for the initial training, and they go back and work in the field and do a field practicum, and then they come back for supplemental training, and then they can be called a parasocial worker. So roughly 2,500 people have completed the program so far. There are an additional 1,500 or so that have been involved in the program and completed at least the first part of it. And the program has now become more sustainable as other groups have gotten involved and have requested our help, oftentimes with PEPFAR funding or involvement with other groups. And so what happened basically was that we were asked to scale up and expand this program, and since then we've taken it to Ethiopia, where we called these people psychosocial care workers, to Nigeria, Zambia, and there are others that are sort of in the process of rolling out. So I tell you this story partly because we want to give you examples that I think are useful to share, and a lot of what the Alliance is about is sharing examples, but also because embedded in that story are a lot of points that have become issues that in terms of deploying paraprofessionals in social services. And one of the issues that we will come back to over and over again is the idea of a career ladder, that parasocial workers, para-child and youth care workers, para-community development workers is an entry point. And I will ask people when they tell me about their programs, what level of preparation do these people have? And very often they're people who have completed high school equivalent, whether it's called Form 4 or grade 10 or grade 12 or whatever. They have basic literacy skills, hopefully, because they're going to be asked to record information. And people have tried to do it with people who have less education, and that becomes challenging. And I'm told that I need to go a little bit faster, so I will do that. So the notion is that it's a career ladder, and as people move through that ladder, that's actually an achievement, as opposed to being seen as a retention problem. So the Alliance, when we first did our surveys and collected information, decided that we should have interest groups. And the first interest group that was identified was to deal with paraprofessionals. And Zenny and I have been trying to facilitate this group via conference calls and email, and once in a while some face-to-face connections. And we talked to the group about what they thought were important issues and something that we should be working on. I'm going to tell you a little bit about each. The issues that they wanted to work on are going to be reflected, but the project that they took on was developing a set of functions, competencies, and implications for programs and for training. And so that's an ongoing process, and we invite you to be a part of that. We're kind of in the middle of trying to get into all of this. And one of the first things that we came up with was issues about who are the paraprofessionals, what do we mean by the paraprofessional social service workforce, if there is such a thing, and what are they called? And there are many different names, and they mean different things in different contexts and in different countries, and you'll hear about some of them throughout today. The three that the group is working on are parasocial workers, who I've already mentioned to you, para or auxiliary child and youth care workers, and paraprofessional community development workers. And you will notice that there's a lot of overlap between these three, but they each have specific and unique functions tied to specific disciplines. So here are some of the challenges and what we try to do about them. One is, very often, if there is a country that has a professional social service definition and structure, how do we attract people into that system? And it's not just a matter of getting them degrees, because oftentimes people will get degrees and go on and do something completely different, but how do we engage them and sustain them? So we believe that paraprofessionals are one of the answers to that in terms of linking them in, and hopefully they will progress or they'll stay in place. And some of the programs have been put together specifically to get people to stay in place in their communities. The second one is to ensure adequate opportunities to prepare for and meet demands to serve vulnerable children and families. And isn't this really what this meeting is all about? Figuring out ways to serve those needs. Vulnerable children and families, and perhaps other vulnerable populations. And so there we think that certification and linkage to employment are critical issues. The next is that if there are official workforce staffing plans and schemes of service, and this goes back to what we did at the Cape Town conference, the government linkage, that paraprofessionals should somehow be integrated and recognized as part of that. And the government and the private sector have clear descriptions of each. And of course we have to talk about training. And one of the issues with training is how long should it be, what should be included, and what other training is going on, and how they overlap or conflict with each other, and how they can be harmonized. So this is another issue that needs attention. Then, do the paraprofessionals have the resources they need to do the work, including some kind of compensation, at least for their expenses, if not for their time? And so that's another important kind of issue that we've dealt with. How do we ensure ongoing supervision and management structures in place? Do we have a human resource database? Can we provide follow-up? Can we sustain what we're doing? All those kinds of issues. And finally, how do we document what parasocial workers achieve? And note that I use the word achieve, not necessarily outcomes, which is very difficult to deal with, particularly at the client level. But at least can we document what they're doing and some of the results of that? So some of the ways that we can address that is, all of these challenges, is to use the Global Alliance as a resource. And if you look at the web and the resource information, it's voluminous. However, I want to share a secret. Everyone doesn't go to the web to get information. And if I have a criticism of the Alliance, if I can possibly say something in this setting, is that oftentimes we think technology, when what we need to think is face-to-face interaction, and we need to figure out ways around that. So that's why idea sharing and network is extremely important. Advocating with government and civil society organizations to utilize paraprofessionals in appropriate roles. As I told you, we're working on developing guidelines or competencies and functions for paraprofessionals. So maybe we can agree at some point about what is a paraprofessional in the social service workforce, what are the subgroups, and what should they be expected to do and how they should be evaluated. I've talked about the career ladder. And also it's important that we collaborate with others who are doing education and training in country, particularly professional schools on curriculum, certification, and in some places they've actually managed the infrastructure of doing this training and support. And finally, how they can be involved in emerging professional associations as associate members or the like before they go off and develop their own associations, which are somehow going to compete with everything else that we're doing. So coordination is the key, and these are some of the ideas of how we pulled this together. Thank you so much.
Thank you for the opportunity to introduce the community child and youth care worker and the South African Isibindi model. Just a little bit about who are child and youth care workers. Child and youth care workers are frontline direct workers who work in the life space of children. They use ordinary daily life events in ways that are therapeutic and developmental, providing child-focused services which are family-centered. Child and youth care workers operationalize children's rights in service delivery. And the core of child and youth care work is relational work, where engagement and connection is a core of services to families and children. The Isibindi model, and Isibindi is a Zulu word meaning courage, is a model of community-based child and youth care workers providing both family support and family preservation services. We work in diverse communities in South Africa, and I think it's important to know that we are servicing in remote rural areas, as in this picture. We're also working in informal settlements and shanty areas, as you might call them as well, which are difficult areas to work in. This is an example of a service where children are playing in a deep rural area where there are no parks and recreational places for them. This is an informal safe park that has been created by the child and youth care workers for children. This is a picture of one of the most remote areas that we are working in, where children have been continually going down to the river to collect water. The child and youth care workers in servicing these children have not only worked with them in ensuring that they go to school and that they're eating and they're receiving their grants. In addition, they've actually dealt with the issue of water. All these children now boil their water. The child and youth care workers have been to school and ensured that all the school children could take the message back to their families. They're working in partnership with social workers and community development workers, the health workers and the teachers to do an advocacy campaign in the area to see that there could be running water for children. It just actually emphasizes that child and youth care workers, by putting children at the center of services, do understand the comprehensive nature of the services that they provide. So I just want to make the point that Isibindi is a comprehensive strategy to key human rights issues: protection and caring for children and youth, responding to HIV and AIDS, responsiveness to poverty and the issue of unemployment. In the development of child and youth care workers, local-based people are recruited and trained and deployed to work in the communities to service children and creating employment for child and youth care workers. We are concerned about the issue of rural poverty, and the Isibindi model is contextualized to the unique rural realities in South Africa. It focuses on the skilling up, development and empowerment of women. And just to say, I think that the Isibindi project has approximately 85% of our workforce is a women's workforce. And we respond to the issue of disability. You can understand the issue of a cerebral palsy child in a rural area and the kind of support that is required from childcare workers. I have a picture to show you about that. Isibindi is a social franchise model, which means the model should be replicated in a similar way around the country. There are certain core replication principles: that all childcare workers are trained, and they are trained with an accredited training by accredited trainers and assessors. Child and youth care workers are mentored and supervised so that you help them translate the theory that they've learned into practice, drawing as well on their own practice wisdom. It's a partnership model. The NACCW, as well as civil society organizations, governments and funders, have worked together to develop the model. And at this point, I want to acknowledge the funding received from PEPFAR, which has complemented government funding in creating a model that can be upscaled in South Africa. The Izibendi model promotes a child and youth care approach to service delivery. It uses child and youth care methodology. I think when Nathan spoke, he talked about there are various social service workers that exist. Child and youth care workers are not social workers, they're not psychologists, they're not community development workers. They are a unique profession that is showcasing their services to children in the context of families and community. We are also committed in Izibendi to build a flexible, accountable work ethic. When I say flexible, I think it's just important to note that in building a children's workforce, it's important to work the hours that children need you. Children go to school. If people work from 8 to 4, they spend at least 2 hours with children every day. Child and youth care workers in the Izibendi project work mornings, evenings, weekends, public holidays, and school holidays particularly. So they work the other, sometimes we say 23 hours, the hours when children need them the most. And of course, we make sure that they don't work exorbitantly. They work according to what labor law would allow, but they work children's hours. Developing a workforce that responds to children according to the hours when they need them is critical in Africa. So Izibendi is a turnkey model that is actually able to promote scale-up. Henry Meyer, one of the child and youth care theorists, says that the quality of care is not so much a singular question of how the workers feel about children, as it is about how do they translate their care into actions. Now, child and youth care workers connect with children. They build relationships with them through the use of ordinary daily life events. They help the family with basic household chores and educate them about general hygiene, gardening, health, nutrition, and household care. They cook together with children. They teach them basic life skills and they build resilience, using ordinary human interaction as the context and a means for transcending basic care to meet the emotional needs of children. So when we actually bath a child and when we cook with a child, we're actually cooking food that Ma cooked when she was alive. And immediately that food is not just filling the stomach, but just filling the soul. We are especially sensitive to this in child-headed households and parentless families, which represent a large number of children that we service in South Africa. This is just some pictures to show you how we work. This is what a childcare worker said to me, that when I come to see them, they run and they hug me. They are so happy to see me. The childcare worker here is helping a mother who is seriously ill and cannot care for her children in a child-headed family. The little girl is taking responsibility for her siblings, but the childcare worker is sharing that responsibility. The mother is in the picture because she is there. She's not excluded. It is a family preservation approach, so she's possibly sharing comments, commenting, and being part of this process. In this picture, this is a gogo or granny-headed household. The children of this granny have died, leaving her with her grandchildren, both of whom are under the age of 6. The child and youth care worker is stimulating them in their homes, using a bag of toys and playing with the children, and in keeping the granny engaged in the activity. Homework supervision and education is a core responsibility of childcare workers. Generally, there are no children who drop out of school in the Izibendi project. They're all going to school, and we've got the challenge that many of our children are passing successfully through high school and are asking us for their bursaries and for their opportunities to study further. Many have university education, many passes, and many are at universities as we speak. This is an example of a child and youth care worker with special training responding to a child with disability. This is part of the responsibility of the Izibendi childcare workers. So some of the critical success factors, Izibendi does meet a legitimate need in South Africa. We are not servicing children that are serviced by anybody else. We're actually servicing children that require us to be there. It's a cost-effective model. In South African rands, it's about 200 rands per child per month to be serviced with, and this includes the fact that the child and youth care workers would be earning a salary. It's a national model that is adopted to local contexts, so as much as it is replicated in a particular way, it is nuanced to suit the different communities that we service in South Africa. It articulates social policy. It's completely in line with South Africa's Children's Act and other broad policy and legislation. There's broad-based ownership of the project. The project is co-owned. Everybody who's part of the project feels that it belongs to them. The implementing partners, the funders, the other partners in the process. And in a way, the project is moving towards co-creation, where social workers and others are saying, look, child and youth care workers, for example, in the Northern Cape, we are dealing with the highest fetal alcohol syndrome. How can the model be adjusted to respond to some of these needs? So it has the capacity to adapt and to grow. There's a synergy between the model and the spirit of Ubuntu. Ubuntu is the African spirit that says, I am because you are. And the child and youth care workers feel that their own development is mirrored in the development of children. So as the children are growing in a parallel process, so are they finding their skills and their capacity. And that is, I think, one of the wonderful characteristics of the Zibindi model. It includes many partners, it responds to core government strategies, but most importantly now, it is a job creation program. Government is not looking at it as just a skills development program, but these are childcare workers on a career path who are already in the process of earning salaries for the work that they do once they are qualified. So South African government has an initiative to scale up Izibindi. There will be 400 Izibindi projects with 10,000 trained child and youth care workers who will be servicing 1.4 million children within the next 3 to 5 years. The process has already started. Just to tell you, we started off in 2013 with 286 child and youth care workers. Much of these workers were trained and developed through PEPFAR funding. Government is supporting the rollout. At the moment, there are 2,743 childcare workers in training in South Africa in 221 Izibindi projects around the country. Our planned projects, as I go back to South Africa, we will be working towards training the 5,269 child and youth care workers in our next phase of training. The different provinces have identified the people to be trained. Just a little bit of success. The project, the Minister's Scale Up, has been in operation for a year now, and from April 2013 to March 2014, which is the first year of implementation, we have 225 Izibindi projects operating nationally, which is 50%, approximately 50% of the Minister's target. We have 2,743 workers in training, so we're meeting our 93% of our target is being met, and we've got 97,000 children who have been actually serviced in the Izibindi project. But it's not just about numbers. It's about the child, and this is what a child said to me when I spoke to her. He said that when Auntie Zed came, things changed. I started to dream my dreams again. And child and youth care workers, in the way they work with children, are able to bring hope and help children dream again, and not just focus only on have a bed to sleep in and do you have food to eat. Nelson Mandela said that he would want to see that the landscape of children to be changed in South Africa, and we hope that we are making our small contribution to his dream in changing the landscape of the way children are treated in South Africa. Thank you very much.
Thank you, and our final speaker is Kendra Blackett-Dibinga.
Going to come up. Do I keep scrolling? Okay. Thank you. All right. Good morning, everybody. I'm very happy to have this opportunity to present on a research study that was recently completed in Ivory Coast. And I actually want to thank two people in the room, because it was on their visit to Ivory Coast that the idea actually was born. Beverly Nyberg and Nicole Benham had met with one of our program coordinators and mentioned that there really isn't much about how community caregivers are really impacting health and clinical outcomes related to HIV. And we thought we were seeing this in our program primarily because the program was focused on the entry criteria actually had to do with HIV, some type of HIV positive diagnosis, whether of the children or the caregiver. So I'll talk a little bit about our program from Ivory Coast, which is funded by PEPFAR. It started in 2008, reaching about 35,000 children in about 8 regions of the country. The study that we are talking about today was just conducted, as I mentioned. We finished the analysis in December, but we used data from 2010 to 2013 implementation period, so I'll be discussing that today. For some background on Ivory Coast, it has one of the highest adult HIV prevalence rates in West Africa. HIV-related orphans and vulnerable children are about 400,000. 61,000 of those are living with HIV. Of course, our community caregivers, they're actually being trained by local organizations, international organizations, and they're really at the forefront of providing the care and support to the vulnerable children and families that are identified. They are usually members of the community in which they work, and they offer support through home visits and linking families to particular services. They do assess the family's needs, refer them to appropriate services, and provide emotional, psychosocial, and practical support. In some cases, actual food and then educational support so that children can actually attend school. They do receive training from our program in coordinated care and generally case management using the PEPFAR services as a guide. We also introduced training on gender because we were finding that we were finding many more boys in our households than the girls. This change, and that's the focus of another study that I'll be interested in talking about at some other point, because we were finding that we weren't actually locating the girls for a particular reason, and that's something that we had to really highlight within our program so that we were getting more of a balance. They also receive training in child protection. They generally are considerably invisible, though they do a majority of the work. And I must say that Ivory Coast actually does have qualified social workers who staff social centers, but there's one of them for a large population, and so the community caregivers actually serve a very critical role. They are not remunerated beyond giving a travel allowance, and nor are they officially recognized by the state. So the objectives of the study were really to investigate the community caregiver impact on access to health care and social services for vulnerable children. We looked at the range of activities carried out by the community caregivers and their impact on clinical, in particular, HIV testing and ARV adherence, as well as social outcomes. We also wanted to understand the support needs or barriers that the community caregivers must overcome to provide quality care. And this is an important topic because some of these community caregivers are actually HIV positive themselves. Whether or not they are getting the particular support they need to access treatment, to access livelihood support is an important challenge for us. And we wanted to identify a way forward for this workforce after the project ends, which will be in the next few months in September. We use a mixed methods approach to evaluate the impact. So it was a quasi-experimental design to compare an intervention group of about 512 households who actually received the support of the community caregiver, and then a control group of 212 households who were very vulnerable and were supported by organizations but were not receiving a home visit. So they were not necessarily having direct contact with somebody who would support their access to particular services. We selected these from the regions, five of the 8 regions in Ivory Coast, and then we did interviews with 74 of the community caregivers who work for the 13 NGOs that Save the Children supports. This control group included vulnerable children who lived in the same intervention area as the intervention group. So here are some results. On average, those with the community caregivers had been seen by that community caregiver, the same one, for about 2 years. 86% of the households indicated that they had a high level of satisfaction from that interaction. Over 68% of those who were receiving that household visit received 5 to 8 services of the 10 that were actually provided by the organizations. And then we saw higher levels of uptake for HIV testing, which was great. Further, those children who were receiving support from the community caregiver were 27 more times likely to access nutrition and food services. they were 48 more times likely in getting psychosocial support, 28 times more likely in getting household economic strengthening. And this is also linked to the caregiver also being having support of a social group. In most cases, many of these caregivers were linked up to a VSLA, a Village Savings and Loans Association, and actually we were seeing a lot of money being generated from those groups, which was an incredible, I think, result for us. They were 3.2 times more likely to have been tested for HIV and 9.3 times more likely to be adhering to the treatment if they were on ARVs. And I mentioned this already, but you can see that those who actually had a community caregiver were accessing many more services than those that did not. Really, it was quite remarkable, the number of services that weren't being accessed, even when the need was there and services were somewhat there available. So I'll go quickly into the significant challenges and barriers that the community caregivers face. Of course, our program did provide some small stipends, but this is, really to cover their transportation needs. But the caregivers were providing many more services than what we were providing them funding for. They were cook for the household. They were bringing additional kind of support things from their own pockets. The limited funds, I think, and their informal status render them very vulnerable as a result. And so we, as we're thinking of how we create, in a sense, an advocacy agenda for the government of Ivory Coast to take up this workforce, we have to consider what is the cost of that and how can they really support them for the long term. There really is no insurance to protect them at the workplace, and as they are viewed as volunteers. And even though they're, one of the things that we noticed in our program is that though the social center existed, that social center, because they saw that the organizations were taking care of children affected by HIV, they literally would refer those children onwards. So the social center wasn't even providing the first point of service for those children, and therefore the burden came to the NGO. And then in reality it was a community caregiver that had to support those children. There really is no formalized linkage as of yet with the Social Center for Supervision and Support. Nathan mentioned this issue around a paraprofessional having a supervisory relationship with some formal system. That's not necessarily there, and there's no plan necessarily from the government to further uptake this workforce. So as a result of this study, we are actually doing a complementary kind of review of kind of the costs associated with this, because we do think this is an important aspect that for the government of Ivory Coast to look at, especially based on the results that we found. So we do want to advocate for the official recognition of these community caregivers as part of the workforce, formalize their status with clear job responsibilities. And I think that's something that Nathan also mentioned. How do we improve remuneration for the CCs beyond the travel allowance? Again, this is why we're trying to do that cost analysis to see, what's feasible, what's realistic. And then we saw that, we need to improve some of the NGO structures to systems and structures to actually support them. Some of them were receiving, from the more formalized and bigger NGOs, they were receiving much more support, much more supervision. From the smaller NGOs, maybe not so much. And so how do we kind of standardize that, and including training, the evaluation tools, and looking at how we can have reliable comparisons. So if you have a really highly performing, community caregiver who's having excellent supervision, versus another one who is just doing what they can. And we want to recruit the CCs with a common set of performance criteria across the NGOs. And I think this is also something that, as we're looking at further uptake, what that actually means, because I don't think the NGO will necessarily come out of that process. It will definitely continue to play a support role, but how do we place government more centrally in that process? So in conclusion, we saw that those who were supported by the community caregivers had better clinical and social outcomes. The community caregivers supported OVC accessed the program services at a higher rate than those not being supported by a community caregiver. And definitely, we think that the CCs have an important role to play as it relates to adherence to treatment, improvement of psychosocial well-being of caregivers, and increasing overall access to services and support. So I thank you for your attention, and I'll stop there.
like to thank all three of our speakers for really just wonderful talks with very impressive results. We've heard about an effort to define paraprofessionals and their skill set and competencies, and then a full-time based program that is the Bindi, and then a volunteer program. So I'd like to invite our audience, both our virtual audience and the people in the room, to ask questions, whether it's for specific panelists or for the panel in general. Yes.
Thank you very much, Kendra. Thank you very much. Evelyn Tomaszewski with the National Association of Social Workers. It's a fantastic panel. Kendra, I was just scribbling down the numbers of the results of really incredible. 48 times accessing psychosocial care, 21 times health strengthening, 3.2 times HIV, 9.3 adherence. Those are amazing, amazing numbers in terms of how we can help children access care, how they can stay healthy, how we can grow community. And then I heard you say, but there is no formal uptake. So being a social worker, I need to ask the question, what would be that message? How would we help? How would we help governments see the value of uptake?
Okay, well, thank you for that question, Evelyn. I mean, I think studies like this are really important. We do have constant communication with the kind of body that's responsible for orphans and vulnerable children at the national level, and we've shared these results with them already. But it always comes down to cost. So we need kind of, both the program view as well as the kind of economic view so that ministries of finance can actually budget for this. I don't think it's that people don't necessarily want this. I think this is, as you said, it's incredible that they can actually have a significant impact and help countries reach their overall goals as it relates to child well-being. But governments also have real constraints and budgets that they have to consider. So I think for us, we're looking at how to integrate this structure seamlessly into those social centers, which have definitely received a lot of support, but also make it practical for governments to. I think the case, the kind of ethical and moral case is already there. And, we don't want these children to necessarily suffer if we can see that there's definitely use and impact as it relates to this kind of interaction. But definitely, I think we need to get that round out the analysis with how governments can realistically take it up. Yeah, no, exactly. But when I heard 444 million for South Africa, for example, and then I consider Ivory Coast, it's not the same. I mean, it's a totally different context and a potential tax base and all of that. So I think that I think it's very important. And I must say that Ivory Coast, in this particular area where we are working, also suffered, from the political violence of the last few years. And so all the children, in a sense, are very, very vulnerable. So how do you allocate resources to just a section of a portion of children? It's really how do you make the social center available to support all those children that are very, very vulnerable.
And I think Kendra and her team have taken the first step towards that by doing both an impact evaluation and an economic evaluation. I think we have to continue to tell the human stories, which put the personal, the human face on it. But really, gone are the days where you can just get by with the human stories. You need the economic data. You need the impact data. I mean, I'm astounded that it's 9 times more likely to be compliant with art. So you should take that data and go to the Ministry of Health and say, when you're deciding whether you need more clinicians or maybe more social service workers, we have this, this synergy effect or this accelerant effect, and can make your clinical teams much more effective. I think we need to make that type of argument, but we need the data. I saw a number of other hands. Yes.
Carl Henn from American International Health Alliance. And greetings to Kendra and Nathan and Zani. And I have a question for all three of you. Sorry for my voice today. I've got a cold. We've heard about the social welfare assistant model and the PSW model that were pioneered in Tanzania, and now with AIHA support to Nathan and his colleagues and now replicated by Save the Children together with AIHA in Nigeria and Zambia. And we've heard about the model, the Izabindi model that Zeni described. Are we moving towards a franchisable model now? Do we have enough evidence that we could support this as an international standard? And how would we go about doing that?
Okay, so I think that it varies in terms of the three different projects or the projects that we've talked about this morning in terms of how franchisable it might be able to be, and we've heard certainly about how Isabindi has been doing this. I think with regard to the paraprofessional social service models that have occurred so far, I think we need to acknowledge that they are still developmental, and the kind of evaluation data that Kendra has pointed out is very rare. And so we are split between trying to get things just in time on the ground very quickly, which many of us have been encouraged to do by our funders and sometimes by the government as well. But then when it comes time to actually implement on a larger scale or integrate it or provide funding to sustain it, then we hear a different story. So I think I've become more and more suspicious and critical as I've done this kind of work because things that I used to take at face value, I try to interpret and figure out the levels of meaning that are below, particularly on the political level. And as the players change, then also some of the progress changes that you've taken into account. So my view is that it's a model that we can see is useful in various kinds of ways. And we have some data that really suggests that it's useful. Sometimes it's tricky because there are things like research reviews and NRDs that we have to deal with in order to even talk about these programs. And so I think on the side of what we're trying to do from a perspective of funders and groups that are represented here, there's a lot of promise to these programs, and I think it's worth it to get them on the ground and begin to implement them. But to actually talk about franchising them, I think that's challenging. I think that the Alliance can help us share these experiences and try to figure out which are the best practices and how we can move ahead as we're continuing to develop it.
We see the Izibindi model as a non-profit social franchise model, and it has been designed and constructed in a way for scale up. So there are elements that I mentioned in my presentation that are your non-negotiable replication principles, which allow a model to be scaled up should it suit a country. So and some of those elements that I mentioned were that everybody is trained, and they train in the same training in the same way, that you're working towards a particular vision in that training. I think that you're needing to be aligned to government policy. So each country would be different, but you have to align to government policy if you want to scale up in a country. And it does allow for a standardization of service delivery, but at the same time, in social franchise, to be sensitive to custom design and to be available to fit local nuances. And I think the blend of both is a wonderful way, I think, of contributing to scaling up services to children and families.
It's often a fine line between standardization and making something inflexible so you can be responsive to local needs. Alex, do you have any questions? Any other questions? We can take one more. Is there anything that the panelists want to say to sort of add to the conversation? Final point.
I would just mention that we did bring copies of the report, and they're on the table over there if you're interested. If we've run out, we can email it to you as well.
Thank you. I think now we're going into a 15-minute coffee break. So the panelists will be available